The next layer which we are going to study in the eye is sclera. We have done with choroid. Okay, so the next layer is sclera. So briefly discussing about the layer sclera. So what is basically sclera? It is the white, it is whitish in color. The sclera layer is whitish in color. So the whitish part you can see in your eyes, that is nothing but sclera. Okay, now it forms the posterior part of the outermost layer. Okay, so it is the posterior part, it forms the posterior part of the outermost layer, and we studied this before. Okay, now the thickness of the sclera, the thickest part is around the optic nerve. Okay, so the thickest part of the sclera is around the optic nerve, and the thinnest part of the sclera is posterior to intersection of recti muscle. Okay, so the thinnest part is at the posterior surface. Posterior to what? Posterior to recti muscle. Very simple. Okay, now what are the layers of sclera? As we discussed in cornea, here are also some layers of sclera. So what are those layers? These are, the first comes is episclera, the episclera. Okay, and it is reddish hue, it is a reddish hue. The sclera proper, it is violaceous hue. Okay, it is violaceous hue. So you see two hues, that is in episclera and the sclera proper. Okay, now this reddish and violaceous, these colors are helped us to diagnose in inflammatory conditions. Okay, so how we are going to diagnose it? So if there is an inflammation in the episclera, the inflammation would be reddish in appearance, and if the inflammation is in the sclera proper, it would be violaceous in appearance. The color would be violaceous or red. Okay, so what we are going to do, basically we are going to use 2.5% of phenylpharine. What is phenylpharine going to do? So phenylpharine is going to vasoconstrict what? The blood vessels which are supplying the episclera part. Okay, now if the blood vessels got vasoconstricted, then the reddish appearance would be eliminated. Okay, the reddish appearance would be disappearing or eliminated, and this is known as blenching. So you'll see blenching over here. Now how to identify that which layer was suffering from the inflammation? So what we are going to do, we are going to apply 2.5% of phenylpharine. If the phenylpharine, after applying of the phenylpharine, gives us a violet color or bluish color, then it is crystal clear that it was the inflammation of sclera proper. Okay, and if after applying of phenylpharine 2.5%, if there is no redness, no violetness, then it is clear that the inflammation was in the episclera. Very simple. Okay, so here this phenylpharine is going to do vasoconstriction. Okay, in the episcleritis condition, in the episclera. Okay, now there is no blenching or no vasoconstriction in the sclera proper, and that is why only we can differentiate the inflammation of these two. Okay, here will be vasoconstriction, no redness would be there after application of phenylpharine, but here violatiousness will be there after applying of the phenylpharine, and this will indicate that it was an inflammation of sclera proper. Very easy. Now in the vasoconstriction test, there is no blenching. Okay, and here blenching is seen. Okay, due to vasoconstrictory effect. Now tenderness is present over here, and here there is no tenderness. Then another, episcleritis is idiopathic. It is due to an unknown cause in most of the cases, whereas commonly associated with systemic diseases like rheumatoid arthritis. The scleritis is commonly associated with systemic diseases like rheumatoid arthritis. Okay, and episcleritis is idiopathic with an unknown cause, and this is in the most cases. Now coming up to the third layer, that is lumina fusca. It is also called as the innermost layer. It is also called as the innermost layer, lumina fusca. Now opening in the sclera. It opens in the sclera. So basically in lamina fusca we are going to study the openings. So in the lamina fusca there are some openings. Okay, the optic nerve opening basically. Okay, not even optic nerve, many other structures are over there. So let us see what are the openings in the sclera. So the first comes is the lamina cribrosa. Cribrosa, we all have studied cribriform fascia. It is same like that only, just the structures passing are different. Here there will be optic nerve. So discussing about what is cribrosa. Cribrosa is nothing but it is a sieve like structure. Okay, it is a sieve like structure, like a sieve, and from this sieve, and it allows the optic nerve to pass through it. Okay, the optic nerve fibers are passing through this cribriform fascia. What else structure we can see? We can see cortex vein and anterior scanary artery, vein and nerve. These are structures we can see. Now the next comes the limbus. So we have discussed it earlier that limbus is nothing but it is present at the corneoscleral junction. So limbus is nothing but where the cornea and the sclera meets, that part is known as the limbus. Now the important thing about limbus is it contains the stem cells, and stem cells are what? These are pluripotent cells, as we know. Okay, so they have the ability to differentiate. Obviously stem cells have the ability to differentiate. Then the location of these stem cells is, these stem cells are located at the palisadeates of Vogt, very important. Okay, and the universal marker for the stem cells is CD34. Okay, now a special marker for limbus stem cell, that is ABCG2. But if someone asks you what is the universal marker for the stem cells, that is CD34. Okay, now coming up to route of ocular drug administration. Okay, very important students, routes of ocular drug administration, how we are going to give a drug via the injection, okay, in the eye. So basically there are 7 routes for administration of drug in the ocular. What are all those? So basically we have to know about the layers first. So the outermost is conjunctiva, then comes the tannon capsule, and the 3 which we studied, these lamina fusca, sclera proper and episclera, these 3. So these were the layer. Now accordingly when the injection or the drug would be administered or given in these layers, it would be having different names. Like if we administer the drug in the conjunctiva, it would be called as subconjunctival route. Okay, subconjunctival route. If we administer the drug inside the tenon capsule, it would be known as subtenon. This is the subtenon space. Okay, in the tenon capsule where we are going to give in this subtenon space, obviously. And this route is known as parabulbar route. Very important, parabulbar route. The next comes is episclera. We can give the drug in episclera, no. So what is the next route? The next route is tropical route, that is nothing but eye drops and eye ointment. Okay, so the first route subconjunctival root that we studied. The next comes is parabulbar root. Yes, parabulbar. Is this a root? No. What is the next root then? Then that is the topical root that includes eye drops and eye ointments. Very simple. We all know eye drops and eye ointments. We have applied it. So in the parabulbar root, also called as subtenon space, because the injections are given in the subtenon space, and this is known as which technique? This is known as Nozick's technique. Nozick's technique. Okay, students. Now the fourth route that comes is intravitreal route. Okay, so in the vitreous chamber we are going to inject that. Okay, the next comes is the intracameral injections. Okay, so in the anterior chamber of the eye we are going to inject the drug. The next comes is parabulbar route, which we studied, and it is used for local anesthesia. Very important. The next comes is retrobulbar. Okay, so parabulbar route and a retrobulbar route. Let us see a brief about this retrobulbar and parabulbar route. So here you can see the image, parabulbar and retrobulbar. Okay, so these are your both the eyes, right and left eye respectively, and here is the base of the orbit. Okay, the base of the orbit and the medial wall of the orbit. Joining the base of the orbit and the medial wall of the orbit, imaginarily it gives us a 45-degree angle. Okay, and this is known as the apex of the orbit. Okay, the apex of the orbit, this. Okay, this point. Now there is a lateral wall and obviously a medial wall would be here. Okay, now the next comes is the angle between the two lateral walls of the orbit. These two lateral walls, the angle between these two is 45 plus 45, that is 90-degree angle. Very simple. Okay, now a very important structure, that is annulus of Zinn. It is a ring-like structure at the apex of the orbit, and the muscles originate from the annulus of ring except inferior oblique muscle. Okay, where are the peribulbar injections given? They are given in the extraconal space. And where is this space? This space outside these muscles, you can see this space is nothing but extraconal space, and the space inside these muscles, this is nothing but intraconal space. Okay, so extraconal space, peribulbar injections. Okay, and retrobulbar in the intraconal space. Very easy. Okay, peribulbar in extraconal, retrobulbar in intraconal space. Okay, and these are the spaces respectively. Next, moving on to the points over here. The points in retrobulbar and peribulbar, these are angle between the two lateral walls is 90-degree, as we discussed. The annular zinc, it is tendinous ring at the apex of the orbit, as we studied, and all the ocular muscles except inferior oblique takes origins from the annulus of ring. Okay, except inferior oblique. In peribulbar region, it is in the extraconal space, and retrobulbar injections, these are given in the intraconal space. Now the next comes is the middle layer of the eyeball. Okay, so the middle layer basically of eye is known as uveal tract or vascular layer of the eyeball. Okay, it is known as the uveal tract. Very important for the vascular layer because it is highly vascularized, the middle layer. Now The parts of the middle layers are iris, ciliary body, and choroid. Okay, we'll discuss them all in a brief detail. Just we are looking to the parts. Okay, so the parts of the ciliary body, these are pars plicata and pars plana. Okay, so pars plicata is the anterior part and the pars plana is a posterior part. Okay, then coming up to the choroid, functionally the choroid, so functionally we used to say that iris and the the pars plicata are the anterior uval. Okay, these are the anterior uval, okay, of the middle layer, and functionally the pars plana is the intermediate uval and the choroid is the posterior uval. Okay, based upon the position anteriorly, intermediate and posteriorly. Okay, very easy. As you can see in the diagram, iris iris and the pars plicata these are anteriorly situated. Okay, then pars plicata, it is intermediately situated. Okay, pars plana is intermediately situated, and at the posterior aspect you can see the choroid. Okay, so this is the sequence. So discussing each of them one by one, that is, first comes the iris. Okay, first comes the iris. The iris have two zones. These are pupillary zone and the ciliary zone, and in between lies the collaretta. Okay, which is the thickest part of the iris. Okay, and it represents site of attachment of pupillary membrane. Okay, important. So it is the thickest part of the iris and it represents the site of attachment. Site of attachment of what? Site of attachment of pupillary membrane. Two zones, pupillary zone and ciliary zone. In between, collarate. Okay. Now the thickest part is the collarate and the thinnest part is the root of iris. The thinnest part is the root of iris. There are two muscles. Two muscles. So the pupil is controlled by these two muscles named as spherical pupillae. Spherical, the name itself suggests that it is circular in shape. Dilator pupillae, the name itself suggests us dilation is the function and it is radial in shape. Okay, very easy. Now based upon the function and the nerve supply, these two muscles respectively. So if dilator pupillae is used for dilation, then sphincter pupillae would be used for constriction. Constriction lead to meiosis, we all know, we have studied in our lower classes, and dilation lead to mydriasis, we all know this also. So meiosis, constriction of the pupil, and dilation of the pupil is known as mydriasis. Very easy. The nerve supply to the sphincter pupillae is by the parasympathetic nerve, and these cranial nerves are 3, 7, 9 and 10 respectively. These are parasympathetic supply and these are to the sphincter pupillae. Now the dilator pupillae receives the sympathetic nerves. Okay, the next comes is ocular nerve supplying to the sphincter pupillae, and this is third cranial nerve. This is the oculomotor nerve which supplies to the sphincter pupillae. Now the inferior branch, which also supplies to the inferior oblique muscle. Okay, so the inferior branch also supplies to the inferior oblique muscle, and it has short ciliary nerve is also supplying. Short ciliary nerve is also supplying to the sphincter pupillae. The dilator pupillae, long ciliary nerve is supplying. Okay, so here basically in sphincter short and in dilator long ciliary nerve is supplying. Very easy. So there is something called as the Horner's syndrome, and this is nothing but ocular sympathetic palsy is known as ocular sympathetic palsy is known as Horner's syndrome. It leads to the Horner's syndrome. So let's see in detail what is Horner's syndrome. So what is basically the clinical features for Horner syndrome? It includes HI, Maple. This is the mnemonic. So the first thing that is occurring in this syndrome is meiosis, and this is there is no dilation due to which it causes meiosis. The next comes is anhydration. Hydro means water, and anhydration means there would be a absence of water, due to which ultimately the sweating would be lost, okay, or the secretions would be lost, okay, very simple. The next, that is ptosis, and this ptosis is due to Mullerian muscle palsy, okay, Mullerian muscle palsy. Then comes the L stands for loss of ciliospinal reflex, okay, ciliospinal reflex are lost, okay. Then comes the next comes the Inophthalmos, okay. So we all know about exophthalmos, that is bulging out of the eyes, okay, bulging out of the. So inophthalmos is nothing but the eyes are getting shrunken and getting inside the orbit, okay, this is anophthalmos. So basically it is nothing but shrunken eyeball, very simple. The next clinical condition is coming is heterochromia iridis. Okay, heterochromia iridis. Hetero means different, and chromia means the color, and the iris is iridis. So basically, there are going to be two different colors in your both the eyes, and this is because of heterochromia iridis. And this type of clinical condition, it is seen in only congenital cases, okay, this is seen in congenital cases only, okay. And the last thing, this eye, this is nothing but inferior eyelid elevation, inferior eyelid elevation. So the inferior eyelid is elevated, and the above eyelid, the superior eyelid is depressed, due to which the eye seems to be like it is closed, okay, it is closed or narrowed, okay. Now the next comes is the diagnosis of the Horner syndrome. It is tested by 4% of cocaine test. Okay. In this, we apply cocaine for the dilation. If dilation occurs, then it's okay. It is normal. If there is no dilation, then there is a palsy. Okay. And it is Horner syndrome. Now, the test is used for localization of the lesion. Okay, and these tests are amphetamide and adrenaline test. So basically if cocaine test is positive, then we will move on to the localization of the lesion, this amphetamide or adrenaline test, okay, if the cocaine test comes positive. So this is the test. We applied 4% of the cocaine, okay, and on the pupil. If the pupil dilates, it's normal. If the pupil doesn't dilate, then this is Horner's pupil. If it is Horner's pupil, we will confirm it by amphetamide or adrenaline test, okay. In this, if the Horner's pupil dilate, then this is first order central or second order in the preganglionic neural lesions could be there. Okay. If the pupil dilates in the Horner's pupil, first orderly it is central. In second order it is preganglionic neural lesion. Okay. And if the Horner's pupil does not dilate, it is third order pupil, and there would be a post ganglionic neural lesion. So the lesion would be in the center if the pupil dilates. Okay, this is first order. The lesion could be preganglionic, and this is second order if the Horner's pupil dilate. And if the Horner pupil does not dilate, this is a third order lesion and it is in the postganglionic neuron. So as we studied in the Horner syndrome, the mnemonic included meiosis. Okay, so in Horner syndrome there would be meiosis. So presenting a differentiation between meiosis and mydriasis. Meiosis is seen in Horner syndrome. Okay, hemorrhagic pontings also. Another, it is seen in iridocyclitis. Thirdly, it is seen in clonidine use or carbonic acid use, in organophosphatase or opioids use. It is seen by parasympathomimetic drugs use or by phenothiazine or pilocarpine use. Meiosis is a common factor in sleep and sedative use. Okay, so in sleep and in sedatives, there is meiosis. Coming on to the mydriasis part. It is seen in belladonna poisoning, and internal ophthalmoplakia. Then it is seen in glaucoma, and it is seen in oculomotor nerve palsy. Mydriasis is seen in oculomotor nerve palsy. In atropine use, tonic pupils, and sympathomimetic drug use, there is mydriasis. So in such all conditions, or by the application of such all things, we can see meiosis and mydriasis. So the next comes is the ciliary body. We have discussed the ciliary body in the previous topics also. So the anatomical part have been discussed in the previous, and functions now we have to discuss. So the first function is secretion of aqueous, that we studied also, that the ciliary body is the one who produces aqueous. Okay, now the next function is accommodation, and it is used for the near vision. Okay, a part of near reflex, that is, so basically accommodation is a part of near reflex. And what all three changes in accommodations we can see, that is firstly accommodation itself, then convergence, and meiosis as we studied. So these are the three changes in the accommodation of ciliary body. Okay, now ciliary body helps us in far and near vision. So discussing about the far vision, that is due to, so basically what is going to be for the far vision, what all changes you can see in the ciliary body in the far vision. So these are respectively, these zones are stretched. Now what are these zones? These zones you can clearly see in this diagram. These are the zones, these are the muscles which are being stretched. Okay, the anterior surface of the lens is flat, so the anterior surface of the lens gets flat in the far vision, as you can see in the diagram. The parallel rays of light comes into the eye and converge onto retina. So the light which will be coming parallelly, these will converge and these will go onto the retina. Okay, converge onto the retina and the image will be formed. Now any x power of the convergence of the lens, so it has a x power. For near vision, this was for the far vision. Now coming up to the near vision, what is going to be in the near vision? So the ciliary muscles would be contract, there they were relaxing, ciliary muscles would be contract, the zones, the zonules are going to be relaxed, as they were contracting over here, they were stretched over here. They are going to be relaxed. They are going to be relaxed over here. The anterior curvature of the lens is increased. Now there was flat and now the anterior curvature of the lens is increased, bulged out. Okay, then there the rays were coming parallelly from far, and here there would be diverging rays, okay, which will be coming from a near object, what you were seeing. Okay, and here the power required will be 2x power to converge the rays. Okay, 2x power, there was x power, here it is 2x power, doubled. The lens, there is no changes in the posterior curvature. Okay, the posterior curvature remains the same. Okay, the anterior posterior diameter of the lens increases. Okay, this increases because the anterior curvature of the lens increases, due to which the anterior posterior diameter also increases. So you can see the diameter has increased. Very simple. The next very important topic, that is anomalies of accommodation. The first thing comes here is presbyopia. Presbyopia, what is this presbyopia? It is a physiological change, it is not a pathological change. Physiological change means it is a functional change. Okay, the functional change which is made inside the eye. So in presbyopia, we are going to suffer from a near vision problem. There would be a near vision problem, and it is very common, as because it is physiological, it is not a pathological. So it would be a age related problem. So approximately after 40 years of age, an individual is going to suffer with presbyopia. Okay, and this is a physiological insufficiency of accommodation of vision, and it is near vision accommodation problem. And the patient commonly complains of inability to read clearly, as because it is near vision problem. So what is the treatment of presbyopia? It is spectacles, and spectacles for positive convex lens. Okay, convex lens, so it will increase the vision. Okay, increase the vision. Now the power of the spectacle depends upon the age. In presbyopia, the power of the spectacle depends upon the age. Every 5 year the power is increased by 0.5 d. Okay, so every 5 year, like from when we count from 40 years of age, the problems get started, and at the 45 year of age you will be having a point. So at 45 year of age you will be having a plus 1 d, that would be the number. At 50 years of it will increase by zero point 0.5 and you will be having 1.5 d in plus. In 55 years 2, and in 60 years 2.5 d, and so on. Okay, so what we have to remember, every 5 years the power increase by 0.5 d in presbyopia. Okay, and this presbyopia starts at the age of 40 years of age. Now the patient in presbyopia is emmetrophic, means he wears the monofocal spectacles. Okay, and this is for the near vision, as we discussed. So it is emmetrophic. Now the patient who already use spectacles, now they have a problem. So they have to use both for the near vision and for the far vision, both. So they will be using some different kinds of spectacles, and these are called as bifocal spectacles. These are D in shape. D shaped lenses are over there in these spectacles, and these are bifocal spectacles. These are the older models and nowadays it is prescribed to the pediatric aphakia. Okay, and this is the image for the bifocal spectacles, D shaped. You can clearly see D over here, D shaped spectacles. Okay, the nowadays used spectacles, these are progressive spectacles, and these are like this. You will be having a lens in the spectacles. Okay, so this is bifocal, and here you can see a progressive lens. Now we'll discuss about some anomalies. Okay, so spasm of the accommodation. How the accommodation can be spasmed? So it can be due to ciliary muscle paralysis. Okay, so there would be completely permanent contraction of the ciliary muscle, due to which there is a spasm of the accommodation. Now the focus is at the near object, okay, due to contraction. So there would be a problem in the far vision. Usual, there is a focus on the near object, so there would be a problem in the far vision. Very simple. Now some special in the accommodation mimic myopia. Okay, some specials are like these accommodate and they mimic like myopia, and this is known as pseudomyopia. Very simple. Now what is the treatment of this spasm of accommodation? It is cyclophagus. Okay, so the treatment of, so the clinical condition is known as cyclophagia, and we use atropine as the drug of choice for spasm of accommodation. Okay, very simple. Now the next layer we will be going to discuss is choroid. So basically choroid is the posterior part of the uveal. Okay, and it lines the retina. It lines the retina. Very easy. So that was all about the anatomy of the outermost layer. Okay, now in the next session we are going to discuss the innermost layer.